to Jack Gauldie, who really needs no introduction. We're looking forward to what's on his mind this morning, other than shooting himself.
Shooting myself is first in mind. Thanks very much. And before I start, I just want to say really congratulations to Luca and the organization. It has been a fantastic meeting. I'm incredibly impressed with the amount of effort they went into and the success with which it's gone out to. And then secondly, I'd like to say goodbye to those that I'll miss on my way out because I have to leave immediately after the talk, so goodbye.
Of course, if you never let me give your talk.
That's right, I'm just about not to. Yeah. So this is a presentation that a young student of ours, Aaron Fries, supervised by Martin Kolb, has written up, and that's why I was allowed to be the oldest presenter that the conference organizers usually allow. So this is an attempt to come to grips with how we may well be able to explore and exploit the issue of progression of disease, maybe independent of inflammation, but probably dependent on the microenvironment that the disease itself has created. And this is an issue about how does mechanical interactions may well cause activation of an important molecule, the TGFβ molecule. So in the first instance here, this is Marshall McLuhan, who's a Canadian, and in 1964, he coined the phrase, the medium is the message. And by that, he indicated that there was a symbiotic relationship between how the medium influences the message, and the message influences the medium, obviously. But in fact, it was an attempt to demonstrate that context is everything, how the message gets out and what it looks like is everything, and that influences the receptor. In this case, when we were thinking about the receptor being the tissue, and now we'd like to come up with the matrix is the message, and the message is that we have created this new microenvironment, this new area of matrix, and that alone is now influencing the behavior of the cells that arrive into it. So the makeup of that matrix area, or the microenvironment, is at least threefold. There are the cells that are taking part into it. There are many of the mediators that we've all worked on over many, many years to look at. And then the matrix. The matrix is the last one we've looked at. It's the one that we have had most difficulty to look at, and one that we continue to have the most difficulty to look at, because the very nature of matrix is really a large group of molecules which are mostly glue-like, and they are participating in holding up the cells that are the responding cells. So in this case, it's the myofibroblast that is the responding cell, we think, as an important cell. But it is the myofibroblast in the context of the extracellular matrix that's the most important way to try and interrogate this question. So we can see that the cell population and the matrix itself surrounding the individual cells, whether it's in bleomycin, whether it's in models that we use and where we generate the fibrotic response associated with the overexpression of interleukin-1 beta or TGF-beta, or in human cells, it is interrogating that interaction that we're going to have to come to grips with and ask whether or not that interaction leads to the persistence and or the progression of the disease, regardless of how it got there. I think that's the important issue. We're only dealing now with the N-terminal product of the insult or the multiple insults, and we're now dealing with the recreated microenvironment that we're looking at. So that microenvironment has now got many components. And the many components, and I think there's only a few people who are looking at more than one. In the matrix biology, I've been to give talks in the matrix biology groups, and everybody deals with one molecule because that's all they can deal with, but it's a very difficult area to work in. But these are all functional molecules, and pieces of them are functional moieties as well. So it's very, very complex, and the interaction between them, between an individual cell and another cell, they actually is a contiguous nature. And that's not surprising unless you're a lymphocyte that migrates through, or a red blood cell. You're going to be a tissue cell, and the tissue cell is adhered to the extracellular matrix. So there is lots of reasons to pursue that. And also this issue about the matrix and the cytokines that are made. The matrix is painted with many of these growth factors. And these growth factors are not only there, but they are covalently linked to be there. So if you recognize that the first study in which the TGF-beta1 knockout mouse, the first time they examined the phenotype of that mouse was alive, the normal birth was alive for a long period of time before it succumbed to an overwhelming inflammation and death. And the reason that was the case was, what they didn't understand was that maternal TGF-beta had crossed the placenta into the newborn, because these were born on heterozygote backgrounds. The newborns carried the maternal TGF-beta and used it up over a period of weeks until there was no more, and then they died, because when they then had them, the pups from a fully homozygote mating, those individual animals died virtually within 2 to 3 days of overwhelming inflammation. So it's there, it's painted all over, and it's not the only molecule that's there. All of these other ones are there too. That's another important part. And the molecule TGF-beta is critical if we think it's a molecule that's necessary for fibrosis, because it's always made in a latent form, stuck there on the matrix, not just stuck there, but covalently linked through the latent TGF-beta binding protein and the latent associated protein. Those molecules are covalently linked and cross-linked onto the extracellular matrix. That molecule, the active one, we know is not covalently linked, but is held in that protected package of latent TGF-beta. So how do we get to a situation where that is released? Well, there are many ways you can get it. You can throw acid to it, as we all do, to make the activation. But in vivo, we're not sure how that process is. There are many, many mechanisms that have been described. So this is, I thought, a pivotal paper. And this was Boris Hintz's work with WIPF. And this is the paper where he was able to demonstrate with some very sophisticated in vitro experiments that in the myofibroblast, the smooth muscle actin stress fiber was capable of transmitting a force from the inside of the cell to the outside of the cell through the integrins, which then transmitted that force directly through the latent TGF binding protein and the latent associated protein. And if that force of contraction was on a compliant extracellular matrix, nothing happened. But if the extracellular matrix was resistant, in his case he used multiple stiffnesses or collagens in order for the plates, that resisted pulling and allowed the release of active TGF-beta. So this is a potential mechanism in which the entire process, even of breathing with a stiffened lung, may well be adequate to release a small amount of active TGF-beta adjacent to a cell that's now going to respond to it. This is a way in which no inflammation, no other cell populations are necessary, merely a new microenvironment in which that contractile cell finds itself and now is able to make active TGF-beta to the response. That's the hypothesis that Whip and Boris put through. And there are many, many reasons to think that this is not inconceivable. So we needed to go ahead and try and put together a process to investigate it. Now, if you look at the lung and the areas of fibrosis in a fibrotic area, there's clearly issues which would say that we can see mechanical forces of bending, but not all mechanical forces are going to be identical. So there may be different areas where the mechanical force itself is different, larger, smaller, of a different nature. But it's clear that there are many, many ways in which mechanical forces could be seen in this particular type of tissue. So what we tried to put together a system to look at was, can you just use a mechanical force in order to cause the release of TGF-beta? And if you could cause the release of TGF-beta, could you see the product of the TGF-beta being active on the tissue itself? So the sources of tissue we've examined are twofold. Human lung biopsies from UIP patients. So we've got some human tissue that I'll show you in a minute. But the one that's the experimental model is the model where what Patricia Syme here first put together was the model in which we overexpress active TGF-beta in the rat lung. The rat's the best of the fibrotic responders. It's also got a nice big piece of lung for us to be able to work on. So we end up getting a highly fibrotic piece of tissue depending on whatever day we pick the time. So we can get recurring tissue which has a high intensity of fibrosis as our experimental tissue of choice. And what Aaron had done is to put together a tissue bath system with a force transducer and a servo-controlled arm, which allowed him to cause stretch in the tissue, purely mechanical stretch. And using that type of approach, he asked the question, if he can set it up correctly, is he able to demonstrate the release of active TGF-beta into the tissue bath by purely allowing the force to be exerted on the individual tissue. And of course, that's the outcome that we ended up seeing here. This is now the animal that was fibrotic, the animal that received an empty vector. The lung slices are put in the bath. They're subjected to the tensile pull. And in the supernatant, we can see that the stretched animals release an enhanced amount of the active TGF-beta, all from the material that was in total in the tissue. And if you have increased the force of pulling from 10 millinewtons to 20 millinewtons, you got more of the material. Or if you left it on for a longer period of time, you got more of the active material. So picking that particular approach out, he's able to demonstrate clearly that a fibrotic tissue has the capacity to release active forms of TGF-beta only on the basis of mechanical force. It was independent of any protease activities or MMP's activities in terms of the concept of having a piece of tissue. It's in culture for periods of 2 to 4 hours. You're putting mechanical strength on it. Was that all we were doing? The answer was no. It's independent of that material, so it's only force dependent. Release of the active TGF-beta. And the result in that tissue, in the mouse tissue, or the rat tissue rather, was a demonstration that as a result of releasing the active TGF-beta, the TGF-beta then fed back activity on the tissue and induced phospho-SMAD2 expression. So physical force releases the active TGF-beta. The TGF-beta then reacts onto the receptors in the tissue and causes then the downstream activation that we would know would eventually lead to the outcome of enhanced matrix deposition. So it all fits with, I think, what Boris is trying to say was this looks like it is a real thing that we can maybe pursue and ask about how to modulate it, again, independent of an issue of getting the right kind of inhibition that's associated with it. But that was interesting with the tissue, but wanted to ask the question in a more physiologic manner. And so he then went to use perfusion in a rat lung. So this rat lung is made fibrotic, and then we take the lungs out or control lung, undergo perfusion, and ask whether the force of perfusion alone is capable of causing the enhanced amount of TGF-beta. And here is the issue when the animal that had fibrotic was expressed under the high pressure, releasing active TGF-beta again into the tissue and initiating a phospho-SMAD activation. And finally, the other physiologic role was to ask the question in that same tissue whether endogenous pathways of modifying the contraction of the tissue was also capable of doing it. And yes, endothelin-1 in those tissues was capable of releasing the active TGF-beta if it was there in the fibrotic tissue, as we had predicted it was to be. And these are the outcomes now of 4 human lung tissue slices that were subjected to the same protocols we did in the rat. And here's the enhanced release of the active TGF-beta on tensile pulling of the individual piece of tissue. So mechanical forces can either with pressure on changing how the lung moves, or on tensile pull on the ability to make the release of active TGF-beta purely and simply through the transmittal of the individual mechanical forces. So the tissue stiffness, this component isn't really just on the basis of the same matter, because that plastic and this plastic are the same, but they're not the same outcome, and they're not the same stiffness. And it's this cross-linking that we think is a critical element. We've known for many years that fibrotic matrix is abnormally cross-linked. It is linked, for example, not just to collagen, but collagen probably to elastin. And that kind of change of the matrix may well lead to the kinds of stiffening that give rise to the possibility of releasing this small, low level of active TGF-beta and therefore giving rise to progression. So how do we target this stiff? Well, they did have this material called anti-stiff, and then we've tried to resurrect it, but there is no such thing as anti-stiff. And in fact, the issues are clearly that if we can target the signaling, and some of the mediators that people are currently using right now, the TGF antibodies or the receptor antibodies or the small molecular weight kinase inhibitors, that targets the downstream signaling. But really, what we really want to try and target is some of this aspect, the extracellular matrix or that process. And then in fact, there's several, I believe, of the newer approaches now, and the demonstration, for example, the LOXL2, I believe, is really targeting that resistant material, and maybe getting that loosening will decrease the signal that is generated on the mechanical force, and that may be a way in which we stop the issue of progression. And I think I'll just leave it that way because somebody else showed the matrix there previously, but I think this is the issue, that this is an area that we now have some tools to maybe modify, and I think we're going to get some good information over the next couple of years about whether that stiffness is really contributing, and therefore the microenvironment is really contributing to the progression of disease. And so I'll stop there. Thank you.
Jeff.
Jack, thank you. Look, I think the strength of this is that it's in vivo. And you know, it's so hard to do these experiments in vitro situations. So to get that data, I think, is quite remarkable and really helps the field. What it doesn't allow you to answer as easy is the mechanism. So that Gisela Lindahl in our labs some years ago published a JBC paper in which we showed release of TGF-beta, which we think was independent of integrins. So this, she defined the transcription factors on the TGF-beta promoter that led to an increased transcription of TGF-beta. So the question is, although you're implying this is, in your situation, it's via the integrin release system, I don't think you at this stage have the evidence to back that up. Would that be correct?
Well, that's correct. We're doing some of the studies now with a series of the integrin inhibitors. But don't forget, this is a very, very short period of time. There is no possibility that we're inducing TGF-beta synthesis off of an upregulation of the TGF-beta molecule, et cetera, et cetera. Not possible in the time frame that we're looking at. This can only come from existent latent TGF-beta that's around in order to release it. So that's the only one aspect of it, but as of right now, we don't have data about inhibition of any one of the integrins to see whether, in fact, we can modify the release process. It's a relatively thick piece of tissue, and getting some of these molecules into that tissue has proven to be difficult, but we may well be able to get to it by treating the same things in vivo.
So your time experiment where you showed that the time of force led to an enhanced amount, you don't think that's due to the synthesis kicking in at the later stages?
No. In terms of the time frame from the time that you do the stretch to the time you assess whether you've got the release, there's no possibility of having de novo synthesis of TGF-beta explanted out into the tissue and released into the area.
Okay, thank you.
So this was really very interesting to me, and I've thought about this stretch relationship for a long time and haven't had the tools to address it, so thank you for this. I want to ask you your ex vivo mouse lung model where you showed that stretch increased TGF-beta activation. Have you done the same thing in aged mice,
no.
Non-fibrotic lung, but just aged lungs? And
no, we've only pursued this right now with fibrotic versus controls.
That's something you think might be
Yeah, it's very
worthwhile.
expensive. I wanted to stand up and applaud you for working on the aged mouse. If you're ever going to work on the aged mouse, you've got to have an awful lot of money. I mean, to have one aged mouse has got to be in the $4 to $800 for a single mouse by the time you buy it in.
Just seems like it might help you get at the issue of etiology more than just, because if you need fibrosis already versus can you
Yeah.
actually generate it?
Yeah, I agree.
So, Jack, do you think this is due to effects on the cell and altering the cell contraction, or is it a direct effect of the matrix on the complex? And I guess one way you could look at that is by just measuring Rho activity in your tissue slices.
Yeah. So I don't know, other than an experiment in which he did use Rho inhibitors, which did not inhibit. I don't know yet how to interrogate that question. And it is just as viable, because this is I believe the best we can say about this is it definitely shows in principle that what Boris is suggesting has got validity in principle. Remember, we're doing a stretch. You're right, we could be moving the matrix and not having its effect on the cell, and that's giving rise to the release. And that may be by a totally independent mechanism than stretching a cell. I don't know yet how to deal with that one.
Bill?
Yeah, I just had a quick question about your design. Was the stretch and the perfusion, was that within the normal physiologic? I'm not sure if you
Yeah.
could answer that, or if that was super physiologic in terms
No,
of...
the forces that at least the best as we can assess it, the force that's played onto it is within a physiologic force mount. Yeah.
So Jack, I was wondering if you were able to, after the stretch, if you can somehow determine which cell is the first responder in terms of a phospho-SMAD2 signal?
No, we've just done, from the slice, we've just simply taken the sliced unhomogenate nuclear extract and then look for the phosphosmat.
So is it possible to, image the cells or image the slice afterwards and see which cells are the first responders?
I suspect that with the right tools, we should be able to do maybe some two-photon imaging of it, because it is small enough for that.
Thank you.
So Jack, one of the reasons that I like this so much is that a number of years ago we developed this model of the fibrotic reticulum,
Yeah.
where all the fibrosis
Yeah.
was connected to each other, which for us made sense of how it had progressed in the human. And so I'd like you to speculate on whether there's a way to measure in the human the tension in the lung and to come up with maybe this threshold idea where things start to progress.
Huh. Haven't got a clue.
But Kevin, all the old compliance data
Yeah.
that, Calvin, you probably know the answer to that, right? Wasn't there a threshold that whether your transpulmonary pressures reached a certain point where the progression was worse? No? No clean threshold?
But the question that I guess I'm asking is that there's probably the tension's different in the lung. It's not, right, you can measure it globally, but the question is whether you could measure it locally to make a
Isolated, yeah,
statement.
gotcha.
Excellent talk. Thinking of your paper in relation to Vincent's data that he presented with emphysema and fibrosis, and thinking conceptually that as you develop emphysema, the adjacent areas could collapse and change the tension.
Right.
Have you had a chance to look at these different specimens with and without emphysema, and if emphysema might lead to fibrosis?
So no, but that's obviously, if the human system works out a lot on a consistent basis, then I think it could be pursued exactly those questions.
So Jack, that was really excellent. One thing that struck me is that in the control lungs, even when you subjected them to the increased mechanical force, there was almost no active TGF-beta. And what that suggests is that at some point, before the lung is actually being stiff, there's some pool or some source of TGF-beta that's causing that stiffness. And would you like to speculate on what's going on to establish these conditions in the fibrotic lung?
Yeah, the model we use, remember, is it's an adenoviral vector to overexpress TGF-beta for about 10 days. Subsequently, whatever is going on in those lungs is now a program of endogenous gene regulation. Don't know what they are, don't really understand it at all in terms of why it's persistent and progressive. But it now dependent on endogenous processes. And the TGF-beta has to be endogenous TGF-beta as well, because we only overexpress the active form. So, and the active form cannot reassemble itself into the latent form. So everything that we see has to be coming from endogenous programs, and those can be turned on by TGF-beta because it's an autocrine system. So.
Jack, two quick questions. One of them, getting to what was raised earlier about whether or not you're twisting, moving the cell or the matrix. I'm wondering if you put magnetic beads into the cell and do some twisting cytometry without changing the matrix. That would answer potentially that question. The other one is alpha V beta 6 and alpha V beta 8 aren't typical collagen integrins, right? And you're talking about the stiffness, presumably that's going to be related to collagen. So do other integrins like alpha 2, alpha 1 integrins mediate this process, or are you still thinking it's alpha V?
Honestly, haven't got a clue. Until we can get a system where we can put the right kind of inhibitors in and ask and interrogate it, we really still don't even know if it is truly integrin related with the way that we're at. But if we do get it, then we'll be able to maybe look at the mechanism in terms of which of the integrins is important in that kind of system. Might not be the same integrins that are important in all of the systems. And I think where Boris Hintz's latest work and where he's doing cultures in vitro, he's implying that it's the alpha V beta 5 that's an important part of the myofibroblast interaction with the extracellular matrix. That is the way in which this contractile activity is transmitted from the inside of the cell to the out.